Augustine.
कौन ने
आपका
बोल दिया
सेंस ऑफ ह्यूमर, योर सेंस ऑफ ह्यूमर इज रियली
अरे नहीं सर, आओगी सर का सेंस ऑफ ह्यूमर मिलना तो कभी और मजा आ जाता है, एकदम फुल्ली एंटरटेनमेंट। मैं जरा थोड़ी आउट ऑफ टच चल रही हूँ। मैं जरा अभी अभी
थोड़ी
कैचअप करूँ।
सी बहुत ज्यादा।
अभी सर अब नाउ कैचअप कर
खाली
लूंगी।
खाली यू आर डूइंग योर ओन थिंग्स नाउ.
आता बरं आहे ना सर, किती वर्ष करायचंय फॉक्सी फॉक्सी
अंजलि
सावसी
मेरा
सावसी।
कैमरा रिवर्स है
नहीं, but
एक्चुअली ना, इट्स नॉट बीइंग सीन.
but you have to let people also know, na, that you are existing and you are such a good teacher and
पीपल विल डेफिनेटली नो. थोडासा मॉड्यूल्स हे ते सगळं सॉर्ट आउट केलं आणि थोडे बॅकअप जो रहते हैं ना लाइफ के, वो भी सब सॉर्ट आउट किए थोड़े अभी.
so
नाउ
now
आई
you are free
आई एम फ्री.
totally.
नाउ आई एम फ्री. आई एम
Good,
कंपॅरेटिव्हली.
chalo, very nice.
ते पण जरुरी आहे ना सर, खूप वर्ष, 2 वर्ष 3 वर्ष याच्यात त्याच्यात गेले.
I know.
यू आर लुकिंग गुड सर, फिट अँड
Thank
हेल्दी.
you. Thank
हा
you.
गुड
Thank you.
गुड. टच वुड टच वुड टच वुड टच वुड.
Archana is hiding behind the camera. I don't know.
Archana is off and on and busy in cameras, no, nowadays, so she knows how to manipulate it. She's doing it.
ये क्या है, नया लैपटॉप गिफ्ट किया मेरे को, कैमरे का वो कुछ एडजस्टमेंट समझ नहीं आ रहा है, सो आई एम जस्ट ट्राइंग, तो उसको कर रही हूँ मैं.
अरे बाप रे, अरे बाप रे.
चीजें जो होती है ना, तो उनको समझने को भी थोड़ा सा टाइम लगता है.
See you. See you. See you. अनम्यूट कर. ग्रैंड चिल्ड्रन खेल रहे हैं सर पीछे आपके.
मस्ती मार रहे हैं दूसरे.
I know, I know, I know. मजे में है दो.
My daughter's son has also come and my own grandson is also there.
म्हणजे मतलब गर्मी की छुट्टियां चल्लू.
नहीं नहीं, गर्मी की छुट्टियां नहीं.
आम खाने का समय है.
आई नो, नानी के यहाँ रहने का समय है. अभी भी होता है वैसे. माय ग्रैंड चिल्ड्रन इज अबाउट टू कम इन एक 7 days के अंदर.
चलो,
वो भी एक एजेंडा है ना, वो भी एक एजेंडा है बच्चे पालने का.
it keeps grandmothers busy, you know.
Their mother doesn't value that, but हाँ, they keep us busy.
They value or they don't value, but we enjoy.
Yeah, we both, we husband wife enjoy like anything. We spoil them. So their mother gets upset. काय चाललंय, क्यों तुम बिगाड़ रहे हो, मीठा खिला रहे हो, टीवी दिखा रहे हो, क्या कर. मैंने कहा ले जाओ अपने बच्चे. नहीं हो रहा है तो. गर्मी है हमारे यहाँ बहुत.
Archana, I hope you have given my slides to these people, no? Farm.
Yeah, Sudeep has it. Sudeep, you have sir slide, no?
Yes, ma'am.
Yeah, I've already given sir.
Okay, thank you.
Because Sudeep is very prompt and we've been connected with him for many years, since 2020.
Because I really don't know how to go about with these things, so I thought it's better to send it to
Hi,
you.
Jyoti. Unmute yourself.
Jyoti Karande is the instrumental in, arranging all this. Today's.
Good evening, sir. Good evening, ma'am. Good evening, ma'am.
Good evening.
Good evening, Jyoti.
ज्योति को काम दो और नहीं वो, ऐसा नहीं होता है.
Same with the Bhavya
Okay.
also. Bhavya is a great person. She is like a MOC. She'll collect all the slide deck and she'll make sure that everybody's CV is there. And we have really good, sincere people around us. क्यों कविता दी?
Hamisha.
That is very, very important.
Very, very, very. That's the team. Why it's written over
Sudeep ji,
there? You're in a practice session.
Yeah.
Why it's written over there?
you will be playing the lamp lighting after I
Yeah.
say.
Yeah.
Only 1 minute.
Yeah, it's less than minute only.
And then I will introduce Bapat madam.
What
And
is,
So everyone
Jyoti, please brief me the sequence for how we are going to proceed.
yeah.
so just 2 lines of introduction regarding the webinar in welcoming to MP chapter SOVC.
Hmm.
Then I just say that we begin with divine blessings and light the lamp. That's all. And then I introduce you as president of SOVC. You can
Am I
say a
supposed-
few words.
I have to save the time. Do I need to speak or I don't need?
She's not president
few-
of SOVC, she's zonal vice.
No, she's
president.
MP chapter.
Madhya
MP
Pradesh,
chapter.
Madhya Pradesh chapter, sir.
MP chapter.
Madhya Pradesh
President
का
of
program
SOVC
था.
MP chapter.
But she has so many
As
states
MP chapter.
under her. She's vice president of Central Zone.
काय
Yeah,
करायचं? ते
that
राहू
was.
दे.
So
ते राहू दे.
then
ते
अब
वेगळं
काय
ठेवा.
छोटी सी स्टेट को पकड़ के बैठी आप 5-5, 4-4, 5-5 स्टेट की बॉस हो.
बरं बरं सर बरं.
so then Bapat madam, you say a few words. Then I invite Bhavya to introduce Dr. Basir. Then Basir madam says a few words regarding this webinar. Then Basir madam invites Dr. Binu to invite our chief guest.
Why don't you do all those things, shorten the thing, chief guest को बुला लो, and then Archana का lecture रखो. Archana, you want to invite them?
Yeah, invite कर लूंगी मैं, उसमें क्या है?
चलेगा. Hi Vrinda.
Dr. Binu will invite his wife.
हाँ,
She
she is
is
a
a
vice
we
chairperson,
don't
no?
know.
Vrinda,
वो एक
unmute
छोटा
करा.
सब 30 seconds का ही है
हाँ.
कविता दी. So because everybody gets their
And do we ask them to speak also, the chief guest and guest of honor?
yes, of
They
course.
are
Of
supposed
course.
to speak, no? They are
I don't,
supposed to.
Dr. Sukanta sir is, I think he's busy. He will join late. So if he's not present, we will just introduce him. Dr. Srikala, if she comes, she will speak as a guest of honor.
Good
If she
job.
doesn't come, then we just introduce them and start our lectures. Whenever they come,
I think our speakers are more guest of honor
Yeah.
than what guest
Yes.
of honor we have.
yes. So sir is
Okay.
already there. We'll start with his talk.
Yeah. ठीक है. I म्हणता वृंदा, बड़ी मैडम,
Hello, ma'am. Good evening.
unmute करा.
Vrinda, you have to unmute yourself.
वृंदा unmute करा. You are not audible.
Can you do it, Mr. Sudeep,
Yeah,
from
yeah,
your side?
Yes,
Yeah,
yes,
done.
I done it.
सरावगी सर
And
हमारी खास बच्चा है ये एक जमाने का. ग्वालियर. very जैसे ज्योति करंदे है वैसी सुपर होशियार लड़की है हमारी वृंदा.
Unmute only.
Yeah.
खूप मोठा प्रोग्राम नका ठेवू ज्योती. Make it
तीनच
short.
lecture आहे मॅडम. तीनच
Yeah.
lecture आहे.
And
3 lecture आहे
because
फक्त.
people will like to listen sir and
आणि
Mr.
सगळ्या मोठ्या
Mo.
लोकांचे लेक्चर आहे म्हणजे
हा?
सरावगी सरांचं आहे, पायली सरांचं आहे आणि बसेर मॅडमचं. ओनली 3 lectures.
Okay.
Hmm.
So the first lecture is by Archana Basir.
No, by sir.
Then so. Yeah. ठीक है.
Mishra sir is also there. Mishra sir. Good
Sir,
evening, sir. Good evening, sir.
Sir.
सर ओपीडी होगा सर का.
हाँ.
सर अनम्यूट कर लो. सुनाई नहीं दे रहा.
Sir, please unmute.
Audible.
Yes.
हाँ. सर
Yes.
नमस्कार. सर
Yes.
नमस्कार.
Namaskar. How are you all?
Be good sir.
Good. Thank you. When are you going to start the meeting?
7 o'clock, sir.
Hello?
7 o'clock.
7 o'clock. So I think I'm in the middle of the clinic. So can I take
Yeah.
5 minutes time?
Yes, sir. We'll be introducing you as a chief guest just in 5 minutes after starting the webinar. And then you can leave till your session comes.
Okay. So for 10 minutes maybe.
Yeah.
After 10 minutes I can
Hello,
join.
sir.
No,
Sir,
after
Hello.
10 minutes you can
Yes.
leave.
Hello.
Yeah.
Don't go, sir,
Hello,
don't go.
Dr. Sarogi.
Namaskar, sir. After 10 minutes, you can leave, not now.
Hi, good
Yes,
evening,
sir.
ma'am.
Hi, Meenu.
Okay,
Good
I'm
evening,
waiting for
ma'am.
you.
Good evening, sir.
Okay, good evening, good evening.
Dr. Beenu will introduce you, sir. Then you say a
Okay,
two, three
wonderful.
lines and then you can leave. After
Okay.
then you can come back when your session starts.
Okay, okay. So it will be around 7:30, I believe. I mean, 8:30, I believe.
I'll message you, sir, on WhatsApp after
Okay,
the
okay.
lecture's over.
I'll be in touch. In the
Yeah.
meantime, I've started my clinic little earlier. I think
Yeah.
I'll be able to complete it by within half an hour or 45
That would be
minutes.
great. That would be great.
So waiting for 10 minutes, okay? Because
Yeah.
all big bosses are there.
Yes, sir.
The big boss is leaving. Where is the question of big bosses are there?
No, boss, you are the big boss.
Arre baapre. Shikala has joined.
Sikala has joined, yes. How can you make yourself free at such early hour?
I practice till only 3 p.m. nowadays.
Oh, that's nice. That's very good. And my session starts at the evening, so that is a bit problem. And
No, I
the morning
start in
hours,
the
I
morning
have
at 9.
hospital.
I start my work at 9 a.m., 9 to 3, that's all.
No, but 9 to 3 is my hospital. That is basically, what should I say, service rendered by me, more or less free of cost.
I know.
You know that. And this is my private clinic where I serve the patient with little bit of, remuneration.
Correct.
And that's how this poor gentleman runs his family.
I did that for 1 rupee for almost 15 years.
My God.
I am doing it since last 40 years, Kavita.
Yes, sir.
Great.
Too great, sir. Too great.
Before that,
It's a
I was
value, it's a
1,000 rupees.
valuable contribution to the society, sir, at the end of the day.
I don't
And
know.
I especially
I don't
find Mumbai and Calcutta people, they work differently than what other practices all over the India, I think. It's really commendable and creditable.
Thank you, thank you. With all your blessings, I believe.
Nice. So it's God is giving you the chances to do all those things, I think.
Yeah, I consider myself, yes, very lucky to have this
Lucky
facility
to
in my
be
life.
there. Yeah.
Yeah, definitely. I agree.
Namaste,
Hi,
Sukanta
Anjali.
sir.
Namaste,
Anjali.
how are you?
I'm
Good evening,
good. I'm
everyone.
good.
कुठे busy आहे तुम्ही
Good
अंजली?
evening. Good evening.
Piley sir will be joining soon because probably he didn't get his, could not locate
He
his,
will join in the right time. He's
yeah.
great personality.
Yeah.
I know. He just rang me that Arshana, please send me my this thing link, can't locate. So just resent him. So soon he will join. Hi Anjali, how are you?
I'm good. Good evening, everyone.
Good,
Good
good evening.
evening.
Good evening, ma'am. Good
Hi
evening, Vrinda
Bino.
Joshi, Good
Hi
ma'am.
Bino.
Dr. Beenu.
Hi,
Good evening,
Shrikala.
madam. Good evening. Good
Hello, ma'am.
evening. Good evening, Kavita di.
Hi, मैं तेरे को बोली अंजलि, how are you?
Good evening, Dr. Srikala. Welcome.
Shrikala madam.
Where is Dr. Sikala? I couldn't see her.
She also.
Sir, namaste,
Namaste.
good evening.
Hi.
I
Hi,
could see
Kavita madam.
Binuji,
Hi,
Archana
Shrikala,
ji.
how are you?
I'm fine. Hope everybody is fine.
How are you?
Yes.
अच्छे हैं.
Sir, Sarogi sir, good evening.
Good evening, I said.
Good evening. Archana madam, good evening.
Good evening, Shrikala ji. How are you?
Fine, fine, fine.
Nice to connect on this platform, right?
Yes.
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 So I think it hits 7 o'clock. So can we start?
Yeah, I think we should.
Shrikala, it's she's
Yes,
busy
madam.
in OPD.
Yes.
I know your OPD time. Yes.
I know.
Yes.
But just 2 minutes, I'll be back, madam.
Yeah.
Making it live now. 3,
Yeah, Sudeep. Yeah.
2, 1. We are live.
Good evening and namaskar, respected seniors, faculty, chairpersons, and dear friends. On behalf of Society of Vaginal Surgeons, MP chapter, I find great pleasure in welcoming you to this academic session. In a world increasingly driven by technology, vaginal surgeries help us to realize that true surgical excellence lies in precision, skill, judgment, and respect for anatomy. And so it becomes all the more important that we revisit, refine, and reinforce our surgical skills through this time-tested vaginal route. And keeping this in mind, today's webinar has been thoroughly curated, learning basics from experts. And we are so pleased to have with us a panel of experts who will be sharing their knowledge and skills. They are people who have worked in their field and they have immense experience and expertise. Before we start the scientific session, let us invoke blessings and grace of the Supreme to guide us from darkness into light. It is now my privilege to introduce a leader who has been a constant source of guidance and inspiration to the Society of Vaginal Surgeons, especially the Central Zone. Her dedication to advancing and teaching vaginal surgery has greatly contributed to strengthening our community. She is so passionate about her vaginal surgeries that she says that her passion and profession is same. I know you must have known whom I am talking about. May I take a few minutes to slightly brief her professional journey? Dr. Kavita Bapat, who is president of the Society of Vaginal Surgeons MP and Central India. She is also vice president. She was vice president of Foxy 2021-22, director of Bapat Hospital. She was organizing secretary of AICOG 2022 and an expert in one-day hysterectomy. She has made this popular through various webinars, through all the ICOG courses. She takes them personally, hands-on training, and also online training. Whatever way possible, she tries to disseminate this knowledge of vaginal surgeries. She is also Jogi peer reviewer, initiated registry of primary ovarian insufficiency, editor of Apollo Medicine Hospital, World Book of Records for contribution in medical services, Healthcare Award by Dainik Bhaskar, which is a very prestigious award in Indore. Also winner of NICA Indore and Captain of Industry, Vice President MPOG, Chairperson Breast Committee 2016-18, Vice President MP Chapter of Vaginal Surgeries, Member of Urogynecological Committee AOFOG 2024, Executive Member ISAR and IAGE, Past Governing Council Member ICOG, and President of Indore Menopausal Society. She's an avid dog lover and a coolest grandmother. And we all know she's started the Doctors and Saris group and she's famous, very social person.
Jyoti, thank you.
I welcome ma'am. She has been a great person teaching all around vaginal surgeries. And I request you to say a few words regarding this webinar.
Thank you so much. Good evening, everyone. First of all my regards to Dr. Saraogi, Dr. Payali, our Sukanta Mishra sir, and our own Dr. Shrikala, and all love and affection to Dr. Archana, Jyoti, my own Binu, Vrinda, and Kanare. Anjali. So, and I don't find anybody over there. So that's like, I'm like that. I'm just interested in talking about that. It's my privilege today to address you as a Vice President SOSI. SOSI is a Society of Vaginal Surgeons of India. It's a professional platform committed to promoting science, skill, and safe practices in vaginal surgery, while also supporting the structural training, continuous academic exchange among the gynecologists. So, as my passion is, the vaginal surgery remains one of the most valuable route in the gynecology because it's a fresh, patient friendly. Number two is cost effective. Third is a deeply relevant in everyday practice. At the same time, its skill grows with observation, membership, repeated training, scientific discussions, and why forum is SOFC is so important. So SOFC also does so many conferences, chapters, webinars, and have created a very good opportunity for learning that cover both basic and advanced aspects of vaginal surgery, to the root procedures to complex to up to the reconstructive work. Now, these academic efforts help clinicians to improve their judgment, refine the technique, and ultimately transform the women's lives to the safer and a better surgical care. I also believe that the SOFC represents more of the surgical society. It's not the surgical society only. It represents the movements to preserve, strengthen, and pass the art and science of vaginal surgery to the next generation. So it's very, very important. We all want to do the same, and our responsibility not only perform well, but also teach well, share generously, and keep raising the standards across the country. So I first of all, I congratulate and my all best wishes to Dr. Archana Baser for arranging this for the society, and I'm really proud of Jyoti Karande, Binu Kushwa for making this program in a good shape. And I think we will be able to justify good because you have great speakers today, Dr. Pali, Dr. Archana, and Dr.
Sarogi.
And Sanavi, sir. And nice to see Dr. Sukanta and Dr. Shrikala as our guest of honor and chief guest. Thank you so much. So keep always support the vaginal surgery. Keep vaginal surgery visible, vibrant, and evolving in India. Thank you so much.
Thank you, Dr. Bapat. These were the words from President. Now I invite Dr. Bhavya Doshi to introduce our program director, Dr. Archana Baser.
Thank you, ma'am. So it gives me immense pleasure to introduce our program director, the brain master of this webinar, Dr. Archana Baser, ma'am, who is director, Akash Hospital, Indore. Ma'am holds an impressive list of qualifications like FRCOG and FICOG and has made remarkable contributions to women's health and medical education. She has served in various leadership roles, and she is currently chairperson of ISAR MP chapter, Joint Secretary ISPAT. She has held multiple positions past also, like chairperson, Foxy Imaging Science Committee, organizing secretary ISAR, managing committee member ISAR, etc. Ma'am's dedication, leadership, and academic excellence has earned her wide respect and recognition among peers and juniors, and she continues to inspire us all. Ma'am is also Foxy presidential candidate for election in 2026. So I sincerely thank Baser ma'am for giving me this opportunity to be the MOC for today and for organizing these amazing webinars for us to learn from the masters. Thank you, ma'am, and I welcome you.
Very good evening to all of you. Thank you, Bhavya, for kind introduction. At the outset, let me thank my dear friend, Dr. Kavita Bapat, Vice President, Zonal Vice President of SOFC and President of MP chapter of SOFC. She has been really so generous and kind that just do, Archana, and choose, handpick your speakers and all, So your chief guest and your guest of honor, she has given me free hand, which as an elder sister, she has always done. And we have been working together in different conferences and we have been traveling together. So it's been a long association. And the way this vaginal hysterectomy has been made popular by her, I think everybody now wants to learn the vaginal hysterectomy because what is important that we talk a lot about the advances, but ultimately a bigger section of our society lives in the the lower resources. So vaginal hysterectomy skills, once you learn, I think it does not require a lot of instrumentation, only thing good skills. And to impart these good skills, we have this society. And today we have great speakers with us, Dr. Sarogi, Dr. VP Piley, and we have great team of our chief guest, Dr. Sukanta, Dr. Shrikala. And I was helped by Dr. Binu Kushwa in suggesting all the faculties from the Madhya Pradesh. She is the Vice President of SAOC MP. And we have our friends here, Dr. Anjali Kanhare, Dr. Vrinda Joshi, and I'm sure there will be a great learning opportunity for all of us. So over to you, Dr. Binu, to invite our chief guest, introduce them, and have words of wisdom from them.
Thank you so much, ma'am, for giving me this opportunity. And it's really my proud privilege, first of all, to be a part of SOCSI, working under Dr. Kavita Bapat, ma'am, and a wonderful secretary, Dr. Jyoti Karande, who always conducts all the CMEs in such a gracious way. And it is indeed a privilege to introduce our today's chief guest, Dr. Sukanta Mishra, sir. He's professor and head VIMS RKMSP Kolkata. He has been president of Bengal Obstetrics and Gynecological Society year 2015 and 16. He was founder president of Bengal chapter of SAOC. Then he has been vice president East Zone for SAOC, president Kolkata chapter of ISOPOF 21-24. He is peer reviewer for Journal of Obstetrics and Gynecology of India. Then he is a member of PhD Committee of West Bengal University of Health Sciences since 2012. It's been a long time. And he's faculty for various international and national conferences, examiner in UG and PG courses of different universities of India. And he's editor for Journal of Vivekananda Institute of Medical Sciences since 2017. He has got many publications in the form of chapters in textbooks, papers in national and international journals. His main area of interest are teaching, vaginal surgery, medical disorders of pregnancy, high-risk pregnancy, and contraceptions. It is indeed a privilege for all of us to have you, sir. So we would really like to have some words of blessing from your side as well. Thank you, sir.
Hello.
Yes,
Hello,
sir, you
am
are
I
audible.
audible?
Yes, sir.
Thank you, Dr. Binu, for those kind words. As a matter of fact, at the very outset, I must thank Dr. Kavita, Dr. Archana Bazar, Dr. Jyoti, Dr. Binu, Dr. Bhavya, and many other, Anjali, those who are involved in this SOPSI MP chapter. As a matter of fact, since the establishment of SOPSI since 2018, I was very intimately associated with this. And our primary aim is to dissipate the knowledge across our fraternity, among the different colleagues in different corners of this India, so that the benefit of this vaginal surgery goes to one and all. Ultimately, we must know that the beneficiaries are the patients and the humanity. So taking this cue, there are many societies, many individuals, they have come forward, and we see it's growing and growing very rapid pace. And thanks to the MP chapter for organizing such beautiful CME and webinar and making me a part of it. Thank you, Dr. Kavita and Dr. Archana again for including me in this wonderful session. Thank you.
Thank you so much for being here. Thank you so much.
Thank you so much, sir. Yes, we really are privileged to be here in association with MPOX MP and FOXY also under the flag of FOXY. And for that, we are thankful to Dr. Archana Basair, madam, that we all are sitting together at one platform, different association, and that actually is the need of our. So now I would invite Dr. Jyoti to please introduce our guest of honor for today's event.
Thank you, Dr. Binu. It's my proud privilege to invite our guest of honor for today, Dr. Shrikala Prasad, ma'am. She's Vice President, South Zone SOVSI, Best Paper Award for Management of Stone Disease in Pregnant Patients. She received Best Paper Award for Landscape of Pelvic Floor Disorders in Adult Women, a comprehensive cross-sectional analysis, epidemiological profiling, and correlations with various demographic and obstetric factors. This is an original work done by her. She has 2 publications and two chapters in urogynecology simplified JP Brothers on autologous rectus fascia sling and vaginal apical suspension procedures, multiple chapters in Foxyfocus, and chapter on neurological injuries in OBGYN practice in a book on medico-legal update in OBGYN. I know her as a very intelligent yet a very sober person, a highly skilled but a down-to-earth person, and an extremely busy yet approachable person. Whenever there is a webinar, workshop, class on vaginal surgeries, she is present to share her experience. We welcome you, madam. Can you please say a few words? Shrikala ma'am, are you there?
Yeah, I am there. I'm just
Yes.
unmuted myself. Thank you for the nice words of introduction. We are in such a lovely gathering today with all stalwarts of the field, and we are here now to deliver what best we can to the fellow colleagues and the budding obstetricians and gynecologists. This vaginal surgery is a really not only a science, it is an art which needs to be done the right way. We all know it is very simple, can be done under regional anesthesia. You can see the patient get up and move the next day itself. It's such a simple procedure, no blood loss. And but of course, there are lots of tips and tricks which are going to be shared by the stalwarts. So everything is not rosy. We need to be trained and mentored in the right way for us to carry on the surgery without any problem. Because once we get into any problem, then our hands will ripple back. So better to learn from the masters. And now it is open for our scientific session. Thank you, Jyoti madam, and the entire team, Kavita madam, Sukanta sir, everybody. Thanks a lot. Let's not waste time and go to our.
Thanks, Shrikala, for being with us. As usual, you are the best. Thank you so much.
Thank you, ma'am. Thank you. Dr. Bhavya, could you please introduce chairpersons for the first session?
Yes, ma'am. So moving on with the scientific sessions, we're starting with our first session for the day, that is tips and tricks of vaginal hysterectomy. And I would like to invite the chairpersons, Dr. Vrinda Joshi ma'am. She is working as professor and head of department in Government Medical College, Gwalior, and has achieved Platinum Laksh for the department teaching and practicing obs and gynae since 1994. Ma'am is Secretary Institutional Ethical Committee and Chairperson Teaching and Research Cell, GRMC, Gwalior. She has special area of work interest like in obs, critical care, high-risk pregnancy, genetics and fetal medicine. And she has successfully managed more than 35 cases of morbid adhesion of placenta. Ma'am has also organized first MP State cadaveric workshop for retroperitoneal anatomy, hands-on hysteroscopy workshop and trainings for cervical cancer detection. Ma'am is volunteering for high-risk pregnancy detection drive in villages and sub-centers and with optimum and affordable nutrition for girls and women of all ages. We welcome you, ma'am. Moving on to the next slide. Dr. Professor Beenu Kushwaha, ma'am. She's President ISOPAP Vindhya Chapter and Vice President SOFC MP. She has multiple awards through her name. She has been awarded Best Girl Student Award in MBBS, awarded by International Journal of Obs and Gynae, FIGO Journal for Best Original Research Article for year 2009 on medical abortion. And she is AOGD Silver. She has won AOGD Silver Medal for paper presentation. She was Foxy's West Zone Kamini Rao Orator of year 2015, and she has won Foxy Korean Award for Best Research in the field of obs and gynae. Ma'am is credited with performance of country's first documented out of OTD susceptive hysterectomy with positive fetal and maternal outcome in 2021. And ma'am has established MP's first public sector center of excellence for prenatal diagnosis of hemoglobinopathies at Shyam Shah Medical College, Rewa in 2024. We welcome you, ma'am. Next slide, please. Our next chairperson.
Thank you so much, Dr. Bhavya.
Yes, ma'am. Our next chairperson is Dr. Shweta Yadav, ma'am. She has teaching experience of more than 13 years. She's present president, Medical Teacher Association, Government Medical College, Datia MP, and past president of IMA Datia. She's member of GOGS and IMA Datia, and her MBBS and MS is from GRMC Gwalior. She has actively participated in Hindi translation work of OBGY books for the MP government and published many papers in international journals. She is Master Trainer of Cervical Cancer, Early Detection and Treatment, and Master Trainer of Comprehensive Abortion Care. We welcome you, ma'am. I request the chairpersons to invite our speaker, Dr. Saragi, sir.
Joshi ma'am, would you like to introduce or I should introduce ma'am? Is Vrinda Joshi ma'am there?
Yes, yes, I am there.
Ji ma'am.
It would be good if I get the slide of
Yes.
Dr.
It's
Yeah.
yours.
So I am very happy to introduce you to introduce for the first esteemed teacher and lecturer, Dr. Rajendra Saraugi. He is the emeritus professor and head of the department of Dr. R.N. Cooper Hospital and St. G.S. Medical College, Mumbai, and director of Saraugi Group of Hospitals and senior consultant at Nanavati Super Speciality Hospital. He has been a gold medalist all throughout his undergraduate and post-graduation studies and received 10 medals. Received about 8 awards from MOGS as well as Foxy, including MOGS Quiet Dweller Award, being awarded on 14th June 2025. Patron and founder member of AFG, Zonal Vice President of the same society, UG and PG teacher as well as examiner all over India since 4 decades. It's a long time. Conducted 25 live surgical workshops all over India, that is quite creditable. Written chapters in various books published by Foxy. Received Best Book Award by Foxy on writing a book on HIV in pregnancy. Received most prestigious Foxy Korean Award in 2006 and 7 for devising a surgery called meshplasty for SUI. Presented more than 300 papers and has more than 100 publications in reputed journals, and received a Lifetime Achievement Award from MMA and IMA. I welcome you, sir, and we are delighted to have you as a teacher in today's workshop or CMA. Over to you.
Thank you. Thanks a lot. Good evening, everybody. First and foremost, I would like to thank Dr. Kavita Bapat, Dr. Archana Baser for giving me this opportunity and your whole team. Can I have the first slide, please? Can you make, yeah, thank you. Next, please. Next. Friends, we are grateful to have had eminent teachers like Dr. B.N. Purandare, Dr. D.K. Tank, and S.S. Seth who popularized vaginal hysterectomy. Mind you, I am from Mumbai, so I had these three great teachers with me. Next, please. Why a vaginal hysterectomy? My talk is basically to convince everyone to go for vaginal hysterectomy. Look at these three pictures. First is abdominal hysterectomy, which is the most invasive hysterectomy. Then comes vaginal, which is minimally invasive hysterectomy. And if you look at the last picture, laparoscopic assisted vaginal hysterectomy, which is moderately invasive hysterectomy, you're making so many holes and delivering the uterus. Next, please. We all know vaginal hysterectomy is scarless. Laparoscopic assisted vaginal hysterectomy is minimal scar and total abdominal hysterectomy is scarred. Mind you, what is more important is vaginal hysterectomy differentiates gynecologist from general surgeon. A general surgeon can never think of doing a vaginal hysterectomy. They'll always do a abdominal hysterectomy or lap hysterectomy, but never a vaginal. That is how you have to differentiate yourself from them. Next, please. Why a vaginal hysterectomy? Look at, I purchased these instruments 48 years back when I started my private practice. And I'm still using them, maybe with little modification here and there, same OT table, same instrument trolley. While on the right side, you can see laparoscopic hysterectomy being done. You keep changing the table, you keep changing the stirrups, you keep changing the instruments, you keep changing everything. That is the basic difference. Next, please. Today, in most countries, over 20 to 25% of births are carried out by LSCS. This figure may rise in the future. It is therefore conceivable that the surgeon of tomorrow will be confronted by the need to carry out hysterectomies in women with 1 or 2 cesarean sections. Women who have not delivered vaginally and have had LSCS are vaginally nulliparous and abdominally parous. Hence, every hysterectomy should be considered for vaginal approach unless there is a contraindication. Luckily, with passage of time, indications have increased and contraindications have decreased. This is a teaching by Dr. Shirish Shetty. Next, please. How to avoid complications and conversions in vaginal hysterectomy. Why complications occur? Complications usually occur due to a casual or overconfident approach, which is applicable in any particular type of surgery. Patience and perseverance are more important than the surgical steps. Don't be in a hurry. Learn to respect the tissue and tissue will respect you. Next, please. Before you begin, what's more important is to do pre-operative assessment, fitness, counseling, and consent, which is required for all types of surgeries, pre-operative preparation, and antibiotic coverage. Next, please. Let's look at role of USG. We always ask sonologist friend to do a sonography on our patient, but do we ask them to find out the volume of the uterus? We never do that. That's very important to know the volume of the uterus before you think of doing a hysterectomy vaginally. A normal uterus has less than 100 cc volume, which easily every gynecologist should be able to do it. If the volume is 101 to 200, that means it's a less than 8-week size uterus. Interested gynecologist should be able to do it easily. When the volume is between 201 to 300, the uterine size is 9 to 12, best performed by a gynecologist with expertise. When the volume is between 300 to 400, the uterine size is 13 to 16, needs debulking, which we'll discuss little later on. And when the volume is between 401 to 500, that means the uterine size is 17 to 24. Be scheduled as tentative or trial of vaginal hysterectomy, needs debulking. Consider availability of LAVH and or abdominal hysterectomy. You should explain to the patient and take the consent accordingly. Next, please. What other things are important as far as sonography is concerned? It differentiates between a fibroid and adenomyosis, which is very important before you embark on any surgery. Helps in finding out the various dimensions, size, number, and degenerative changes, etc. in a fibroid. Sonography gives you an idea about adnexal masses. It rules out malignancies. The space on both sides of the uterus can be seen easily on sonography. An abnormal position of kidney or back pressure changes on the ureter may be seen, particularly in a case of procedentia. Sometimes you may find a pelvic kidney also, so you should be prepared to accept that and go accordingly. Endometriosis is present and its various sites can be located. Next, please. Continuing with sonography, you will find adhesions between uterus and surrounding structure on sonography. Congenital anomalies of the uterus, particularly uterus diadelphus, which you can diagnose on sonography. What is most important is the angle between lateral cervical surface and ascending uterine wall of the uterus. Smaller the angle, more difficult is the vaginal hysterectomy. Here in the picture you can see, if the uterus is broad sideways, you will find it difficult, but when it is elongated, it is much easier to perform a vaginal hysterectomy. So when you do a sonography, please look into all these things before you embark on doing a vaginal hysterectomy. Next, please. How to avoid complications in vaginal hysterectomy on table. Proper positioning, lithotomy, exaggerated lithotomy, proper exposure of the surgical site, proper illumination, comfort of surgeon and assistant, proper instrumentation. What is more important is before you wash up, I believe in adjusting all these things. Minute the spinal anesthesia is given, I sit down on the stool and see whether stool is of proper height or not, illumination is correct or not. whether patient has been brought at the edge of the table or not, instrumentation is proper or not, proper draping has been to be done, and bladder and bowel of the patient as well as surgeon should be empty. It should not happen that surgeon is in a great hurry. Proper anesthesia, preferably regional, and blood pressure to be maintained on lower side of normal. Next, please. What are the various contraindications to the vaginal route? If it's a malignant disease, unless until you are well versed with CS cervix, which can be operated per vaginum. However, CIN, endometrial hyperplasia, benign ovarian cyst are not contraindications. If the disease is primarily in adnexa, avoid doing a vaginal hysterectomy. If it's a minimal adnexal disease, it can be done with difficulty. And if you want to do oophorectomy, it's not a contraindication to go ahead with vaginal surgery. If you find cervix is inaccessible, flushed, short, displaced, avoid doing a vaginal hysterectomy. Excessively narrow vagina, avoid doing a vaginal hysterectomy. Virginity, however, is not a contraindication for doing vaginal hysterectomy. Uterine size of more than 12 weeks, avoid doing a vaginal hysterectomy, or there is a broad ligament fibroid, again think before doing a vaginal hysterectomy. But if the uterus is bulky, you may think of doing a vaginal hysterectomy. If there is past surgery of cervical amputation, Fothergill's repair, slings repair, ventrofixation, VVF repair, cystostomy, avoid doing a vaginal surgery or vaginal hysterectomy. However, past surgery of LSCS, myomectomy, conization, A repair, Shirodkus repair, RVF repair, you can still go ahead with vaginal hysterectomy. Next, please. What affects the root? Mobility and descent. If uterus is freely mobile, descent should to the introitus. It's a good case for vaginal hysterectomy. If there is adequate uterus free space, again it's a good case for vaginal hysterectomy because maneuvering is possible. Subpubic arch is normal, go ahead with vaginal hysterectomy. If it's narrow, think of doing abdominal hysterectomy or LAVH. Cervix is normal in size and length. Think of doing a vaginal hysterectomy. It's small, flush, displaced. It will be little difficult for you to go ahead. Fibroid accessible location. Please think of doing a vaginal hysterectomy. It's a broad ligament fibroid or a cervical fibroid. Avoid doing a vaginal hysterectomy. Surgical attitude. This matters a lot. Trained, enthusiastic, experienced will always think of doing a vaginal hysterectomy, while untrained, preoccupied novice will never think of doing a vaginal hysterectomy. Next, please. Give me reliable finding on EUA and I will give you an unambiguous decision on the route of hysterectomy as mentioned by Dr. Shirish. Next, please. What are the findings on examination under anesthesia? Mind you, we have seen the patient in OPD. We have thought of doing a vaginal hysterectomy. But before you think of doing a vaginal hysterectomy, always do examination under anesthesia. And you look for what all things: absence of any contraindication, mobility of uterus in all planes, uterine descent, adequate free pelvic space around uterus. Look for uterine size and volume, free vaginal mucosa around the side of both bladder and rectum. There should not be any puckering. Normal cervical length of portio vaginalis. Next, please. Sometimes we may find it difficult. There can be certain difficulty. What is more important is there is something like a traction test. What is this traction test? If traction on the cervix with a valsalum applied to the anterior and posterior lip separately leads to a finding of external loss remaining above the ischial spines without any descent, then it's not a suitable case for vaginal hysterectomy. Abandon the procedure, please. Similarly, we have dimple sign, a retraction of the posterior vaginal wall of more than 1 centimeter diameter. Mind you, it's the posterior vaginal wall which is retracted by more than 1 centimeter adjacent to the site of pouch of Douglas. When the cervix is raised using a valsalum indicates ovarian endometriosis that has resulted in obliteration of the pouch of Douglas, making the surgical access challenging for the surgeon and risky for the patient and thus contraindicating vaginal hysterectomy. So you have to think of traction test and dimple sign. Next, please. Cervicofundal sign. Inability to visualize the cervix on introducing a large speculum, along with pulling up of the posterior vaginal wall, signifies uterine adhesion on the anti-abdominal wall, seen mostly in women who have previously undergone abdominal surgeries, particularly LSES. In these cases, uterus fundus is at a higher level because uterus is stuck to the anti-abdominal wall. So it becomes very difficult and you may find it difficult. There is something like trial of vaginal route. The way we have trial of labor, we can do a trial of vaginal hysterectomy. That means under anesthesia, you can try and pull the cervix. If it descends below the introitus, below the ischial spine, that means she is a case where you can think of doing a vaginal hysterectomy. Next, please. Next. Difficult situation during vaginal hysterectomy, access to empty pouch. Nowadays, as I mentioned, in Mumbai, we find almost 40 to 50% of the cases land up with cesarean section. And in such case, if you have to do a vaginal hysterectomy, what are the difficulties and what are the problems which you may face? Sometimes in cases with previous LSES, opening up the anterior pouch may be difficult. However, if the bladder is adherent, remember that it is always adherent in the central 3/5 portion and not in the lateral 1/5 portion. That means bladder is always stuck in the middle part, 1/3, 1/5 portion on the right side, 1/5 portion on the left side is comparatively free. This non-adherent portion of the bladder can be easily approached for separation through SAIDS, uterocervical broad ligament space as a surgical window. Mind you, we use the same technique even in abdominal hysterectomy or even in laparoscopic hysterectomy. So why not use it for the vaginal surgery? Familiarity with this space helps in easily finding out the vasicouterine fold of peritoneum and the anterior pouch. And comparatively, let me tell you, it becomes much easier way of doing vaginal hysterectomy and you are not scared of previous 1, 2, 3 cesarean sections. Next, please. Next. Coring procedure. This is best suited for removal of smoothly enlarged globular uterus of moderate size. This is very useful when vaginal canal and or subpubic arch is narrow. With strong cervical traction, the outer myometrium beneath the uterine serosa is circumferentially incised. By this, an enlarged uterine fundus delivers as an elongated sausage-shaped mass. Next, please. Hemisection of bivalving. The cervix is held with clamps at 3 o'clock and 9 o'clock position and traction is applied. Using a knife, the cervix is inside anteriorly and then posteriorly. This incision is carried into up to the uterine fundus, thus splitting the uterus in 2 halves, and it becomes much easier to do a vaginal hysterectomy in these cases. Next comes myomectomy. In case you find that there is a fibroid, it's much easier to remove that fibroid at the time of vaginal hysterectomy. So what you do is incise the capsule, remove the fibroid with the help of myoma screw, and then uterus becomes smaller in size and descends further. Next, please. Wedge morcellation. It is the technique of choice for a grossly enlarged uterus when coring or hemisection fails. Conventional wedge morcellation proceeds through the midline of the uterus. It may be initiated by alternating wedging of anterior and posterior cervical walls up to the isthmic region. When you remove piecemeal, may be viewed as a destructive mutilating procedure. It is useful when the uterus is fixed due to PID or endometriosis or when there is cervical obstruction due to myoma. There is something like Pryor's technique where the anterior morcellation is done. Mind you, any of these procedures which we are doing, you have to think of ligating the uterine artery before you think of proceeding with these procedures. So what you do is here you cut the entire wall of the uterus and do morcellation piece by piece on the entire wall of the uterus. Similarly, you can have posterior fundal morcellation and you can have cant enucleation by Doyen's method. Doyen's method is generally being employed at the time of LAVA, that means laparoscopic assisted vaginal hysterectomy. When the uterus is big in size, the way they keep cutting the uterus on the sides so that it comes out like a sausage. That is Doyen's method. Next, please. Mind you, what is more important in today's world is vaginal hysterectomy is compared with laparoscopic hysterectomy. More and more people are going in for laparoscopic hysterectomy. But if you really look at it, God has given us 5 sensory organs in our body. Eyes are to see, nose is to smell, ears are to hear, tongue is to taste, and skin is to sensation. Mind you, when you do laparoscopic surgery, the skin is not coming in contact with the tissue. The sensory organ of the skin is lost. So that part is there when you do vaginal hysterectomy. Next, please. What are the difference between vaginal surgery and laparoscopic surgery? We all know vaginal surgery is a natural route, one hole given by God, while laparoscopic surgery is artificial, multiple holes are being made. Next, please. After seeing this, I am getting the famous Bollywood dialogue from Chulbul Pandey. I will make so many holes in your body that you will be confused from where to breathe and from where to dash, dash, dash.
Great, sir.
Next, please. Vaginal is always done under regional anesthesia. Laparoscopy is always done under GA with all possible tubes and gadgets inserted. Next, please. Now, what has happened? The gadget insertion was done wrongly, and instead of oxygen and hydrogen was used, and you can see the patient is flying up. Next, please. Condition of anesthetic is always relaxed here. Condition of anesthetic is under tension with eyes constantly on monitor to watch everything. Next, please. What happens? Have you heard about boys trapped in flooded cave? In laparoscopic surgery, you will always find water and fluid all around. And same feeling right now as far as the anesthetic is concerned. Next, please. We give slight Trendelenburg position, while in laparoscopic surgery we have to give steep head load. Next, please. The surgeon is telling the anesthetist, I want more head low. So the anesthetist is asking, you want head low or Sirsasana position as far as surgery is concerned for laparoscopy. Next, please. What is more important, even a first gynec poster gets a chance to do it, while even a postgraduate doesn't get a chance to do laparoscopic hysterectomies. Next, please. It has a short learning curve. Vaginal hysterectomy always has a short learning curve, part of standard teaching during post-graduation. Laparoscopic surgery has a long learning curve, teaching done after post-graduation. Next, please. In today's history class, we'll learn about the iPhone 5. You may not know the basics, but you will try to learn iPhone 5. Next, please. Vaginal surgery is always a conventional surgery. It's very cheap and meant for masses, while this is unconventional. Imagine a laparoscopic hysterectomy done for third-degree uterine descent. It's very expensive, meant for elite class, because doctor has to recover the cost of instruments, gadgets, harmonic scalpel, etc., etc., etc. Next, please. Various prolapse repairs like anterior colporrhaphy, posterior colpopeniorrhaphy, SUI repair can be performed easily through vaginal route. Laparoscopy can't be done for all these cases. If at all, one has to use foreign material like mesh, and you will see the result shortly of all the meshes complication, which is practically banned for all vaginal surgeries. Next, please. Can be performed easily in high-risk cases because you are giving spinal anesthesia. No preoperative preparation required. While difficult to perform, particularly with incisional hernia and previous abdominal surgeries, preoperative preparation required in case of laparoscopic surgery. Next, please. Only 2 nurses are sufficient to help you in vaginal hysterectomy, laparoscopic surgery. Many assistants are required. Many people are required behind the scene, monitoring gases and other gadgets. Next, please. The patient feels I am feeling like I am watching IPL match because there are so many assistants around him. Next, please. Can be performed in rural area in camps where electricity is a problem. Time required is much lesser. Surgeon is comfortable sitting on a stool. Laparoscopic surgery, no, if requires modern theater, time required is much more. Neither surgeon nor assistant are comfortable. Next, please. Here you will see this gentleman was doing laparoscopic surgery and his height is becoming shorter and shorter and the parents are worried about it. Next, please. Complications with a vaginal surgery is much less. Complications are more, including ureteric and bladder injuries. We all know about laparoscopy causing ureteric and bladder injuries. Next, please. No gas is put, so no question of pain at the shoulder or abdomen, no air embolism. Overall patient satisfaction is much, much better. While in laparoscopic surgery, we all know pain at the shoulder and abdomen and risk of air embolism is always there. Next, please. Please inform all your visitors that a videotape of your endoscopy is available in the gift shop, which can't be done in a case of vaginal surgery. Next, please. Technology has stopped him from thinking for himself. He is using his GPS to guide him to the bathroom, and that is what is going to happen if we keep relying only on technology all the time. Next, please. Have you something suitable for my husband's endoscopy photo, please, which is not feasible in a case of vaginal surgery? Next, please. Surgeons are advocating laparoscopic surgery as they have no idea about vaginal route. This is a true thing as far as today's world is concerned. Situation is that we are handing over all our cases to other branches. SUI, VVF and cystocele we are handing over to urosurgeons. Fibroid and hysterectomies we are handing over to lab surgeons. Rectovaginal fistula we are handing over to proctosurgeons. Carcinoma goes to oncosurgeon. Infertility goes to IVF specialists. Menopause goes to Indian Menopause Society people. Endocrine disorders go to endocrinologist. This is the situation today. So what we will be left with will be only deliveries, nothing beyond that. Next, please. A good physician treats the disease and a great physician treats the patient who has the disease, as mentioned by Sir William Osler. Next, please. Let's accept the fact that vaginal route is always the preferred route. If you can't access vaginally, then you can take help of laparoscopy, and if that is also not feasible, you resort to doing abdominal surgery. Next, please. Time has come to conduct learning courses and workshop all over India the way they are doing in Indore or MP Society, just like laparoscopic surgery workshop, in order to remove fear and misconception about vaginal hysterectomy. Friends, forceps vacuum and now episiotomy are becoming extinct due to rising LSCS rates. Similarly, vaginal surgeries and vaginal surgeon will also become extinct one day. Remember, no surgeon can be an efficient lap hysterectomist unless he or she is also an efficient vaginal hysterectomist. Next, please. Thank you. Thanks a lot. Thanks.
Thank you, Dr. Saraugi. It was a very entertaining presentation. We loved it. And very elaborately, you have discussed about all the advantages of vaginal surgeons. And I hope Dr. Kavita will be helping us out. And Gwalior has been famous for lot many vaginal surgeons. Kavita Didi is from then only. And I can just imagine how easy it is for the patient and for the surgeon, as you rightly said. Thank you so much, Dr. Saraugi,
Thanks a lot.
for this enlightening talk.
Raugi sir, amazing lecture, as usual, sense of humor was at height. And the points which you have given, I tell you, it's very, very important. But what the important point is, apart from this, which I feel we need more advocacy for our vaginal surgeries day by day. And whosoever the younger generation wants to learn laparoscopic surgery, they should learn laparoscopic surgery. But before doing the laparoscopic surgery, they should learn the vaginal surgery also. That's my dictum, and I think Dr. Piley is doing great work regarding this by doing and propagating this message. So in every hospital, every institution, every medical college, the first dictum should be vagina first. So it's my way of putting things. They should do the vagina, they should learn vaginal surgery first and then go for the laparoscopic surgery.
I can tell you one thing, Dr. Piley has really rejuvenated SOVC. I can tell you that.
Yeah. He has rejuvenated
He has done a
and put
great
all full
work.
heart into it, really.
Yeah.
So true, so true. And we should be able to meet the gaps between the two. And I think the new generation should know the vaginal surgery much more way.
The problem with us is laparoscopy and endoscopy is being promoted by all the companies which are selling the instruments.
Yes.
Lot
of glamour.
The problem comes.
Yes.
Can I intervene?
Yes, sir.
Yes, sir.
Welcome,
As
sir.
a matter of fact, we are fighting with laparoscopy. This is a fight between David and Goliath. Goliath with all gadgets and David with only a stone chip.
Correct.
You know? And
Yes.
in this fight of David and Goliath, we are just using some of the basic instruments and often, some endoscopic instruments through vagina. But the fact remains, all the advantages that Professor Saraugi has mentioned are there with vaginal surgery. So I would request all the delegates, those who are not pursuing it, please follow the suggestions and tips provided by Professor Saraugi, the master.
Amazing.
Thank you.
Thank you so much,
Thank
sir.
you, Saraugi, sir.
Thank you.
Now we should invite Dr. Piley.
Yes, ma'am. Thank you to all the speaker. Thank you to the speaker. Thank you to all the chairperson. And truly, sir, you are a motivation. Bapat ma'am, you are a motivation. And truly in Indore, we have a good course on vaginal hysterectomy. So we are definitely motivated for it. Moving on to the next session. Can we have the slides, please? The next session is on vaginal hysterectomy with anterior and posterior repair made easy. And I would like to invite the chairpersons. Our first chairperson is Dr. Seema Vijayvargi ma'am. Seema Vijayvargi ma'am is director at Shakuntala Devi Hospital in Indore, and she has 40+ years of expertise and practice. She's president IMS Indore and past president of IOJS Indore, with coordinator of Sangini Breast Cancer Support Group. We welcome you, ma'am. Next chairperson is Dr. Anjali Kanhire ma'am. She's MD FICOG and FAI MER Fellow, GSMC Mumbai 2011 and ACME 2018. She's professor and head of department of obstetrics and gynecology at CMCH Bhopal, and she's president-elect Association of MP Obs-Gynae Societies from May 26 to 28 and past president.
Bhavya, the rest of the things you can leave. Thank you so much.
Thank you, ma'am. Welcome you, ma'am. Our next chairperson is Dr. Jyoti Karande, ma'am. Ma'am is Vice President OBSI, Indore Obs and Gynae Society, and examiner of MRCOG Part 3. She's Secretary SOFC MP Chapter and Joint Secretary AICME 22. And ma'am is for motivation for learners like us. We welcome you, ma'am.
Thank you.
I request the chairpersons to invite the speaker. Dr. VP Pelly, sir. Yeah. Next slide, please.
I'll take this opportunity to invite Dr. VP Pally to address our gathering. We have been reading about him. We have been doing things since he has taught us so many things. But today on this platform, when it is focused mainly on vaginal hysterectomy, I think it is wonderful to hear him again. Sir is National President, Society of Vaginal Surgeons of India, past President, Kerala Federation of OBGYN. He is State Coordinator of Confidential Review of Maternal Health in Kerala. And we all are aware that how Kerala has been doing wonderful work for reducing maternal mortalities. It has been quoted in all the meetings to take the Kerala model and go ahead, especially in MP, it has been quoted n number of times. Consultant, Rajagiri Hospital, Kerala, and special interest in high-risk pregnancy, endoscopy, pelvic floor, and urogynecology. Sir, it is our pleasure to have you on this platform. Thank you so much.
Thank you very much. Can I share the screen, please? I don't see the. Can I
Thank you,
share the
sir.
screen?
In spite of Good Friday celebrations, you have come here. So
Thank
thank
you.
you so much, sir.
Yeah. Can you ask the person controlling to allow me to share the screen, please?
Sudeep ji.
You can share.
Sudeep, will you please allow sir to share?
Yes, allow sir to share the screen.
Yeah, all panelists can share.
Oh,
Just the green button down, you can just click that share.
I don't see that. That is why. I don't see the green button, sir, please.
Please move your cursor a little. You will get that. Cursor a little on the screen. It will come.
So make screen full, and just in the bottom you will see the share screen.
Yeah, the screen is, I have made it full.
Yeah, and then just put a cursor down, go down with a cursor, and you will see the participant chat, share.
Yeah, there I see participants, chat.
Participant chat,
After that,
raise hand, and then share. You put the share button.
Oh yeah, there is a more and then there is a share.
Yeah,
Okay.
yeah. Just don't move your cursor anywhere. Just keep it there.
Okay. Thank you.
Thank you. Sir.
Sorry, just 1 minute. Okay. Sorry.
Sir, please share your slide on my WhatsApp and then share it or
So I have only videos actually, that is why.
there'll be a lot of there'll be big video like
Sir, you can talk on any subject. You just press any button and start talking. Yeah. You don't need, sir, any presentation which has been given to you. You can talk on any subject. And we will love to listen. That's more important.
And so,
You have stopped sharing, sir.
can you share your screen so that we can just tell where to?
Nee. Sir, go again to the sharing button.
Maybe sir can reconnect Dr. Kavita, then he can reconnect or the Zoom.
He knows it. He knows it. Sir, go down with the cursor and share button. Again, press it like previously you did it. Put a cursor and go down. Keep finger on the cursor and go down.
yeah, I'm trying to share, but it's not coming.
No
Can you
issues.
do one thing? Yeah.
Yeah.
Who is the next speaker?
Archana, can you do your lecture first?
Yeah, I can do, but I was just hoping that Sarka Usse steps will be little, so I can go on sacrospinous fixation. But I can do that, not a problem.
Yeah, because
Please go ahead.
please
Meanwhile,
go
I'm
ahead with
trying
yours.
to-
And so
Yeah.
that,
Okay, give me 1 minute, okay?
yeah. So put your cursor down and you can go again like the way you went previously.
I'll just log in again. Thank you.
Should I start or should I wait for the sir?
Nahi, Archana, you started so that by the time it finishes, then people will introduce you after your lecture.
No, I'm being introduced once, so there's nothing like introduction.
Yeah,
So
you start.
I'll let
Because sir has logged out. So it's better you start it and then we
Okay,
can
okay.
have-
Mine is very
Yeah.
short lecture because I
Yeah.
was, hoping that with the sir's steps and
No
things,
issue,
I'll
no
take it
issue.
forward, but
You-
doesn't matter.
Yeah.
So, very good evening to one and all. Thank you very much for the opportunity. This was my very favorite subject, sacrospinous fixation, because what was happening when we started doing like vaginal hysterectomies, I learned my vaginal hysterectomy in MGM plus in the Mumbai when I was with Dr. Daftari and Dr. Shyam Desai, and then that this you can do the this wall still the prolapses are coming after the hysterectomy. That is the wall prolapse, and you really need to fix it. It's not the way forward. They just do a anterior repair, posterior repair, and close the the opening so that nothing is seen outside, because the patient will come back again with the prolapse. So let's talk about sacrospinous fixation. This is an advanced urogynecology technique which involves suspending the vaginal wall to the sacrospinous ligament to correct the wall prolapse or vaginal prolapse. Now, still we deal with the burden of pelvic organ prolapse, and the lifetime risk is up to 11 to 19%, and it has a significant impact on the quality of life. Women in their 50s, in their 60s, they come with the wall prolapse because they had a hysterectomy done, now don't know what to do. Sometimes they feel shy in coming and talking to their even the female relatives there, and this is a presentation invariably with the walled prolapse. Now this is the before and this is the after you have corrected the walled prolapse by the sacrospinous fixation. Now what are the indications for sacrospinous fixation? Walled prolapse, advanced uterovaginal prolapse. Even when you are doing a vaginal hysterectomy, as Dr. Sarogi has said, that you have to do a proper assessment and see that even just doing a hysterectomy is going to correct her prolapse. So you must see that whether I should just reposit the vagina and fix it to the sacrospinous ligament so that she doesn't get the wall prolapse in the future. And the another indication is the recurrent prolapse. This is the surgical anatomy. Our landmark here is the ischial spine. What happens? Sacrospinous ligament is a fan-like ligament, and there are the pudendal vessels which are nearby. So what you are operating in a very vital area where there is on one side is a rectum, there are the pudendal vessel. So once you know your anatomy well and you have learned the skills to do the sacrospinous fixation, it is like a very easy procedure and it can be done by minimum instrumentation. So this is the anatomy of the area. If you look, when I talk to my patients and do the counseling about sacrospinous fixation, because the first question which the patient asks after the hysterectomy, when she comes with the prolapse, why it has happened? Because I've already had an hysterectomy, why this thing is prolapsing? So what I tell her that you really need to fix it here because it is like, the sleeves are inside out and we have to correct it and we have to fix it. Otherwise, it is going to drop again. So you draw the diagram, tell the patient, do the counseling and fix it at the sacrospinous ligament. And this is the anatomy where you have to know your anatomy, that this is your fixation point, sacrospinous ligament, and this is the internal pudendal artery. So that is there. Now, if you look at the standard of sacrospinous fixation, you can do a posterior vaginal approach, you can do the blind suture placement, or nowadays, now, there is a time of the collaboration. Collaboration means you are a good vaginal surgeon and you have the laparoscope with you. So you can just ask someone to hold the scope from the behind and then you can really see the anatomy well. And the most important thing is whatever you are performing, your associates and your assistant and even your students can see it better. So then there is nothing like a blind suture placement and you can view the ligament beautifully. Now, these were the limitation of conventional sacrospinous fixation. It's a blind technique. Let me tell you, initial days when I was doing the sacrospinous fixation, I was used to struggle because your assistants can't see what you're doing. You say, well, you retract the rectum. You will say other person that you retract on one side, because normally we do it on the right side, the fixation, and one will hold your retractor anteriorly. And there was a risk of neurovascular injury. And there was a big learning curve when we were doing the blind technique, because in that hole, you will ask your associates to see, and then you will put your finger, palpate your ligament and the bone again and again. And sometimes you'll do the per rectal examination also, just in the fear that I hope I have not, torn the rectum. So now it has evolved over the time. So now what we do now, it is the sacrospinous ligament fixation with a minimum dissection, direct ligament exposure. And what I have learned is nowadays, though I'm using the Duchenne curved needle, but one of my associate recently told me that they have been using this suture passer. The suture passer is something like an instrument which is used by the orthopedician, where they have this for the shoulder, they do the suture passer, and with the suture passer it becomes beautiful, and your minimum, basically it becomes a real minimum invasive surgery, and that is really, really advantageous for learning and for the patient's benefit as well, and the time taken in the procedure. So you can expose a posterior vaginal incision or you can do the anterior vaginal exposure, whichever way you are comfortable. The first thing what you do is to identify the ligament using endoscope, avoid the blind palpation. So what you should do when you hold the vault and put the stay suture on the vault, just give a little tug on it, do your infiltration like how you do in anterior and the posterior repair. And if you are doing the posteriorly or anteriorly, just make your incision. And once the incision is done, what you do is just with the finger and a little gauze piece on your finger, how you can just separate and make a layer and then separate and make a space, and then you can see the ligament, sacrospinous ligament. So this is the accurate placement, reduce nerve injury risk, and is a non-absorbable suture. So this is how the vault, vaginal vault, is fixed over the sacrospinous ligament, and this is the anatomical depiction of that. Now the fixation, vault suspension, the most important thing is it's a tension-free repair. You know, in the olden days, we were used to just pull the suture and see if the patient is moving from the table, because the patient is under the spinal and you just tug and pull. But I think that has to be avoided, because you don't want to do a tension on your suture. And this is something which I've learned recently from one of my associate, that this is the first pass where you can really just put your suture material, whichever suture material you want to use. You can use the Vicryl or you can use another material, and then just pass it, and it makes your life very, very easy and very simple. So advantage of this suture pass is shorter learning curve, reduced complication, and it is reproducible. The complications of sacrospinous fixation are buttock pain. Many of women will come back that they find it difficult to sit because there is a pain. And in that case, you have to advise them to sit on a donut or some kind of pillow where there is no pressure on while they are sitting. There can be bleeding because you are working in an area which is very, very vascular. So that there can be bleeding. You should know how to control the bleeding. And then you can do initially, because there's a lot of venous oozing there, you just have to put a lot of pressure and stop the bleeding. Sometimes women do come with dyspareunia and there can be recurrence. So whenever you are doing a counseling, howsoever good surgery you may do or good surgeon you may be, but sometimes the patient's tissue is not that, listening to whatever suture you are putting, and then there can be a recurrence, and it depends on the patient's weight and other conditions which can lead to the recurrence. And the outcome of sacrospinous fixation, success rate is 80 to 90%, and there is an improved safety profile. And this is a paper on laparoscopic sacrocolpopexy versus vaginal sacrospinous fixation for vaginal vault prolapse. There's a randomized control trial and prospective cohort study. What they did in this, a total of 179 women, 64 women randomized and 115 women participated in a prospective cohort, and there were no differences in number of reinterventions and complications between both groups. And what they found that laparoscopic sacrospinous fixation and vaginal sacrospinous fixation are both effective treatment for vaginal vault prolapse after a follow-up period of a 12-month. So now the tips and tricks in doing the sacrospinous fixation is stay medial to the ischial spine. That is very, very important. Right side is preferred, and you have to avoid the tension when you are doing the sacrospinous fixation. And with this, I would like to thank all of you for the patience listening, and I seek your support and your blessings for Foxy Presidential Candidate Election 2026, because every member matters. I'll be with you, for you, and by your side. And I also believe in learning and teaching and training. Thank you very much. I hope sir's
Ma'am,
slides.
please start your video.
Thank
Basir
you.
ma'am, please start your video.
Nice presentation, Archana. I think, but one word which I, as being a vaginal surgeon, I like to call upon or say here, that laparoscopic sacrospinous fixation or the sacrohysterospexy, which we call, can be a better and give the good anatomical support. But vaginal sacrospinous fixation offers long-term apical support, simpler, faster, native tissue repair, ideal for older, and it's a very good and for the low resource setting. So I think the vaginal sacrospinous fixation, whatever the theories and results may be, but it is better than any other thing.
Yeah, I agree with you. I couldn't agree more than that, because the reason is because, it requires not many instrumentation, number one. And number two, when there is a vaginal route, when the prolapse has happened with the vaginal route, it's better to be repaired with that route, and you are skilled to do vaginal surgery, so you can do it. But Kavita Di, I found that this instrument is very, very helpful, and you can really visualize with the laparoscopy, but you need one person to hold your scope to show it around to you.
I know, I don't disagree, but we are here at the Surgeons of Vaginal Association of Vaginal Surgeons.
No,
and we
but all of us
vaginal.
have laparoscopy in our armamentarium, where we can just, the light is also very focused and you can see it. And for the training purposes, basically for the training purposes.
I think.
Madam, sometimes we were using the headlight.
Yeah.
Initially, we saw a couple of them using the headlight to see inside, same way what laparoscopic light can do.
Yeah.
So,
Yeah, I was used to use my husband's ENT headlight because
Yes.
we have evolved over the years, many years from struggling with
Sir
the
is
distance.
showing, Rajendra Sarawgi sir is showing instrument.
Yeah, I
Hello?
was used to use that curved needle holder, and the left side and right side different, and that is called Dushan. Yeah, still it is in my armamentarium.
Over to Seema Didi, or who is the chairperson, please. Again, we can tell.
Seema ma'am, please unmute. Unmute yourself. Dr. Seema.
We can invite Dr. Piley again. I think, sir,
Can I just try
ma'am,
whether we can
okay.
share? Can I just try whether we can share my screen?
By the time Dr. Bhavya can introduce chairpersons for the next
Next
session.
session, yes,
Be
ma'am.
fast, Bhavya.
Yes, ma'am. Can I have the slides, Sudeepji? Acha, sir, Pelly sir has started sharing the screen, ma'am.
Yeah, it's perfect. Let the sir speak first, no? Because he has started.
Yeah, these are the ones. Can I start or?
Yeah, you
shall
can
we
start, sir. You can start.
further discussions with the previous one? Archana, thank you very much. Kavita, Archana, the two
Thank you, sir.
stalwarts from
Thank you for
Madhya
joining,
Pradesh,
sir.
and all the chairpersons. Thank you very much. I'm sorry for that hiccup. The funny today is that we have 5 vice presidents for SOSI. 4 of them are here. You have got all of them here, Kavita and Archana.
Thank you, sir.
And it was a wonderful experience to have Dr. Sarogi share his fun-filled presentation, conveying proper messages of decades of experience. I have been asked to talk to you about the prolapse management. There's a general perception that doing a hysterectomy for a prolapse is simpler than doing it for a non-distant vaginal hysterectomy. I think it's far from the truth. So I thought I will share our experience with some videos. And yeah, this is a patient, as you can see, with prolapse, and I will show you how the circular incision that we put in a case of non-distant vaginal hysterectomy, we don't go to the sides. But here, it's safer and better to make your incision all around the cervix because you want to raise the flap of the vagina. Local infiltration with.
Sir, can I interrupt you, sir? We can't see your
We are not
videos.
able to see your video, sir.
Sir, videos are not, you have to click on your video which you want to show.
Double click it and make it flash.
Yes, sir.
Put
Can
your
you see
cursor.
now?
No, sir. We are able to see all your 5 videos, this thumbnails. So you just double click the vaginal hysterectomy edited 1 and 2, which you are going to show, and then you start. Double click it, sir.
Yes, sir, share. You can just put it on the.
Then double click on the vaginal hysterectomy. Yes. Go down, sir. We are able to see your cursor. Go down, sir. Little
Sir,
down.
1 centimeter down, just on the picture.
You are not able to see now?
No, sir.
No, sir. Yeah, sir. Just click twice, sir.
Yeah. Click
Yes,
twice.
sir. Sir, it will play.
Click twice, sir.
Playing. Can you see now?
Sir, I think
No?
no, sir. Click twice. Yes. Double click. It's downloading rather.
I don't know what has gone wrong.
No problem, sir.
Sir, please stop sharing it.
Need to
Just open the file and you share directly the video. Don't share the file, like particular these files. Share directly the video. Now you open the file which you want to play video, and then go to share button and select the video that is playing.
So you want me to minimize this one and then
Yeah, you open the video what you want to play. Then you open the click the share button and you share the particular video that is playing.
Sir,
okay.
Don't share the
first,
folder. You don't share. You just folder directly. You share the video that is playing.
Is the video being playing now?
yeah,
Now-
if video is playing, no, sir. Now you
Now you
share
share
the again share the button and put the cursor on the video. You have stopped sharing, no, sir?
Yeah.
Yeah, it's good. Now again go down and find out the button of share, which we did that exercise previously. Take your cursor down and go up to the level of share. Can you?
No.
Where is your cursor? You are able to see your cursor?
My cursor is not seen on the screen.
So move it twice so that you will be able to see the cursor. Once you see the cursor, take the cursor down, go up to the level of share, press the button, and you can share. And then you put your video on the video and it will start.
Now I am on the share.
Yeah. Very good, sir. Very good. Now just
Can you
yes,
see now?
sir. Yes, 100%. Thank you, sir.
Perfect, sir.
Okay. So you can see that the incision is put all around the cervix, whereas in an NDVH, we don't incise here at 3 o'clock and 9 o'clock because it's better that the vagina is attached to the triradiate ligament. So here you are raising the flaps, going posteriorly so that you can enter the pouch Douglas by opening the cul-de-sac. Once you have opened it, this is a deep cul-de-sac. So you hold it with an Alice. Once you have opened the pouch Douglas, anteriorly you have lifted the bladder. No reason to open the peritoneum anteriorly in the beginning, but holding the uterosacral McIndoe complex with your finger or with a closed clamp. Now you can clamp. What many people do is they take this and then tie this pedicle and leave it long, which I don't recommend because leaving any pedicle long on a tag can make it get loose later. And what is the purpose of doing it? You can easily identify the first pedicle without any problem because it's very accessible. So we have taken care of the uterosacral McIndoe complex of this side. Double ligate it, go one step higher, overlap with the stitching of the pedicle, a little bit of the previous one, and now you are closer to the uterine artery. Once you have reached the uterine proper, you will be at the level of the uterovesical fold as well. This is one thing which we insist, learn to tie with a needle holder rather than squaring the knot with your fingers up there. So this one, because we have reached the level of the peritoneum, this will have the uterine artery also cut. You can see the uterine artery cut, and this pedicle ligation is important. So you take overlapping with the previous stitch on the stump once more, and then see that bringing the needle from behind forwards, just outside the tip of the outer clamp. So these are a few practical points which I insist to our beginners so that they are not likely to miss any vessel. So we have gone closer to the round ligament now. Again, start the first bite at the lower end of the pedicle, come from behind forwards, just outside the tip of the outer clamp. And then what we insist on our trainees is learn to tie with the needle holder so that you can tie at a higher level in the vagina, close to the vault, without your finger having to reach there. So learn to tie with a needle holder, so the knot will be at a higher station. So that way, we have now taken care of the uterus has been removed. Now, if there is any enterocele, dissect the peritoneal circulation, and we can do always in these cases. It's better to do a McCall. We are closing of the peritoneum. This is the way we take the McCall. The triradial ligament, pull down on it, and the posterior fibers of the uterosacrals over there are taken. Then you go across the prerectal peritoneum, go to the same posterior fibers on the opposite side. Now come outside. We use the external McCall, so we use PDS for that, not proline. If you are taking an internal McCall, we can use the proline. The knot will be buried. But if it is an external McCall, you take only PDS. So this is how we do a vaginal hysterectomy. Compared with the NDVH, non-descent vaginal hysterectomy, the difference here is you are taking the vaginal incision all around. You can later reflect the bladder if you have an anterior colporrhaphy, and if you have posterior colporrhaphy, you do the perineal repair later. So that is how we do the vaginal hysterectomy. Again, no, I want to continue to share.
Sir, again, stop sharing. Again, which video you want to show in your video, you just click it, start it, and then again share. You stop sharing. Which video you want to share, show, that you open on your computer and open it, and then again share and press the button.
Can you see now? Sorry, can you see?
Yes, yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
So this is a case, not much of a prolapse, but I would like to show you how we do the anterior repair. You can see the laxity of the anterior vaginal wall over there. And just thought of showing how we approach for the paravaginal dissection. But before that, after the hysterectomy, this is how we do the McCall. And any case with the descent is always better to give an apical support. And here, as I described in the previous case, we are doing the McCall, taken the bite on the posterior fibers of the uterosacral here, going across onto the prerectal peritoneum to the opposite side, take the bite on the posterior fibers of the uterosacral, which are seen held with the Alice there. And finally, you come out on this side at about 7 o'clock position, so that the stitch will be outside. On the other side, you have entered at 5 o'clock. So at the end of the surgery, when you tie it, it will take the vault of the vagina upwards. So that is the hysterectomy done and the posterior pedicle taken. Now we will go to the closure of the peritoneum. Now this is just to demonstrate how we do the anterior repair. So the circular incision around the cervix is now extended vertically. Vasopressin has been infiltrated. So you do an inverted T, and this is the important change that I would recommend. When you separate the bladder, don't push with the gauze, but do sharp dissection. And again, you keep the fascia towards the vagina and not onto the bladder. So that is the difference that we recommend now, because of the experience of having done repair with the mesh where the fascia is kept to the vaginal side. Here also we do the same thing. The advantage is even if you are not using the mesh, if you keep the vaginal fascia, cervical fascia onto the vaginal side, that makes the vagina thick, and you can later approximate the fascia. So this is how the paravaginal dissection is being done. You pull on the cervical edge. You have a curved Alice with sharp teeth. You have dissected and got the bladder separated. Your finger is gone deeper to the vertical ramus, scopomic ramus, and you are taking the curved Alice onto the side, on the surface of the obturator internus, and then you can see it. Keep the bladder pulled medially, and there you can see the Alice holding the facial structure, that is the fascia, on the surface of the obturator internus. Where it is thickened, it is called arcus tendinous fascia pelvis. You take the bite through that. This is proline that we are using. And then you take the proline on the vagina, which you want to become the new lateral sulcus, and you leave the proline inside the vaginal flap so that you can tie it with a knot inside, not buried. You do this on both sides. Once you tie this, you will see that the redundant vagina is reduced, the lateral sulcus is reformed, and you have paravaginal repair or additional reapproximation of the arcus tendinous to the fascia on the vagina. So that is the advantage of this vaginal approach for vaginal paravaginal. You are taking away the excess of the vaginal edges. If there is bleeding, you can just coagulate it. You can see that the vaginal edges are quite thick because the fascia is with that. If there is still redundant vagina, what you can do is take a bite on the fascia on the inside, as we are doing now. Take it to the fascia on the other side, so you have a facial support to the bladder. In addition to taking the paravaginal repair, now the fascia is supported under the bladder. Unlike what used to be done, where you take a purse string stitch on the surface of the bladder, here we are doing additional facial support only and not purse string on the bladder wall. Now we will do a running stitch on the vaginal edge to approximate the edges. We have already tied the paravaginal stitch so that the vagina is not that much to excise. Whatever is to be excised, you excise and then do a running stitch. Along with this, when you have done the apical support, you get a deeper vagina, better support at the apex, better support at the vaginal wall. So that is the anterior repair that we would recommend now. Not only just a purse string stitch to keep the a purse string stitch for that, but hello.
Yes, sir.
I will just show the posterior repair now.
Yeah.
Because these are the three which I have been asked to do.
Yeah.
That's the posterior. If there is time, I can show our own method of doing the sacrospinous fixation. So this is the posterior repair. I hope you can see now. Can you
Yes,
see
sir.
now?
Yes, sir.
Okay.
Yes, sir.
Okay. So your finger in the rectum will tell you how deep or how big the rectocele is. Now you can see that's a fairly big rectocele, not just a detachment of the Dillon-Williams fascia from the perineal body, we are giving the infiltration with vasopressin, which we regularly use for all these tissue planes, so the bleeding will be a little less. You make the incision not at the junction of the pigmented skin with the vagina, but at the level of the hymenal remnant. So it is inside the pigmented skin. The incision depth length is adjusted depending on how short you want the introitus to become. If you want it to be tighter, make the incision longer so that finally it will be a narrower introitus. Depending on the age and the need for sexual activity, you can adjust that. Now we are going to make it an inverted T-shaped incision by incision extended in the midline. Again, as in the case of the anterior dissection, here also we try to keep the vaginal flap thicker, not very thinned out, very thin like that. And once you do the dissection on both sides and go up to the upper part, then you can, that is the fascia which you separate from the vagina. The Denon-Villiers fascia will be identifiable closer to the apex of this incision. And your aim is, that's the fascia being separated out. That's the edge of the fascia, which are detached from the perineal body. So you are bringing it down, and that edge of the fascia has to be brought back to the perineal body so that this gap through which the rectocele was bulging will be taken care of. So you have got the edge of the Denon-Villiers fascia here at the upper end. And then using PDS, you bring that fascial which is separated from the vagina. Now that fascia is brought back to the perineal body. That is the most important part of this repair, so that the fascia, to prevent the rectum from bulging, will be brought back to the perineal body. So that is what we do. Using PDS, the edge of that fascia is brought back to the perineal body. You usually take 2 or 3 stitches for that, so that gap is bridged. So once you have brought back the fascia to the perineal body, the defect which was there, the herniation, is taken care of. And now it's a matter of taking away the excess of the vagina and close it vertically. You have taken an inverted T-shaped incision. So finally, when you close it up, you get just a vertical line. It is not a T-shaped anymore. And when you are taken the excess vagina, if it is you are taken, excised it, now you are doing a running stitch, full thickness of the vaginal edges. As you come towards the pigmented skin, be careful that this point will be then brought to this point. That is how the introitus become narrower. So here you can still adjust how wide it has to be. And when you have come to the close to the pigmented skin, you can stop, bury that knot in that space over there, and then rest of it you can close with deeper stitches so that there will be no stitch on the perineal skin. That's the idea, no stitch on the perineal skin. So you go back inside and tie it so that there is no stitch left on the perineal skin. That is the more painful part. So you're avoiding stitching, having the stitch on the perineal skin. Once you have completed the suturing, you can see there is no skin stitch and the vaginal depth is maintained. Posteriorly, you can adjust the size of the introitus by adjusting the bites that you take. You have a deep vagina, and that is how we do the posterior repair. If there is time, then I can show you our way of doing the sacrospinous ligament fixation. Just a short clip. Okay, so otherwise we'll take up for discussion these three which I have presented.
Divya, you have Bhavya, you have the chairpersons for this session, no?
Yes, ma'am.
Yes.
I have chairpersons for
Please
this.
introduce them.
Yes, ma'am. The chairpersons, can you put them in the slide, Sudeep ji? The chairpersons of this session is Dr. Professor Sumitra Yadav, ma'am, who is President IOGSA, and ma'am is also Professor and Department Head of Obstetrics and Gynecology at MTH Hospital, Indore. And she is she's Chairman MDSR Committee Indore Division, Mahila Utpidan Samiti. And she has multiple ongoing research projects also, and she's expert member of District PCPD Advisory Board, District MTP Board, and District ART Regulation Committee. Welcome you, ma'am. And I invite you for your comments on sir's session. And our next chairperson is Dr. Dr. Elizabeth Jacob, ma'am. She's MD, MRCOG, and she's a senior consultant HOD at Apollo Edlux Hospital, Kochi. She's National Joint Secretary, Society of Vaginal Surgeons of India, and South Zone Coordinator, Foxy Vaginal Surgery Committee, 25 to 26, and member Foxy Urogynec and Pelvic Floor Repair Committee. And ma'am is also recipient of FIGO Award for Best Papers at multiple conferences. We welcome you, ma'am. And our other chairperson, Dr. Sukanta Mishra, sir, who has been introduced previously. So I request all the chairperson to give their expert comments on the session that we just had. Thank you. Ma'am, Sumitra ma'am.
Yes, good evening, everybody. It was a pleasure listening to experts on such nice topics of vaginal hysterectomy. And what do I say to the session that Dr. Paili has shown us the various methods, and I hope that the PG students who are listening would be really benefited out of it, because that is my usual question in exams: the enterocele repair, the rectocele repair, and the cystocele repair, and what are the precautions.
Sure.
Thank you, ma'am. Bapat ma'am, I invite you for your expert.
Dr. Elizabeth is there. Elizabeth.
Yes,
As
ma'am.
usual, sir, that the videos were great. I think Elizabeth will like to speak, and then I'll speak.
At the outset, let me thank the SOPSI MP chapter for organizing this wonderful webinar, I think on very basic topics and very well from the greatest experts that we can ever gather. Sir's presentation, I have no words. Always a pleasure and always a great opportunity to learn from each step. I think a lot of innovation, the concept of prolapse itself has changed over the years. Sir clearly demonstrated how the anterior repair is also the small nuances of how to go ahead, identify the paravaginal defect and repair it. I think that's the biggest learning that we have to take today. Regarding how the anterior repair is done, so that there is the maximum recurrences occur from the anterior compartment. We all know that, and so I think this would be a bigger step that we need to learn today. And regarding the posterior repair also, sir's meticulous method of actually identifying the defect and going for the site-specific repair of the Denon-Villiers fascia. I think that's again a very valid step, and also a very important point that sir highlighted, that the age of the patient and the patient's sexual interest, even at 60 or 70, we are nobody to judge on them to decide how much to do a proper posterior repair. I think that's also a very important point, and keeping to the mucocutaneous junction rather than involving the skin so that the patient's pain will be much reduced. I think a lot of these points we have always tried to inculcate, and I think today again it was a great honor. And I thank the MP Society, especially Kavita ma'am, Dr. Archana ma'am, Dr. Jyoti, and everybody for this great opportunity. I think sir will have more points to discuss with us. Every time we sit on sir's webinar, there's one extra point that again I think I have sat on many more opportunities, but every day is a learning. Thank you so much, sir.
That's true, so true. I just like that, even that the pain and dyspareunia because of the mucocutaneous junction. That's really.
Ma'am, I think the anterior repair part, I think, is a big revolution
very,
that sir has
very
taught.
important, very important point. It's a very small point, but putting a stitch on the skin instead of just preventing it, it's really good. I think that's another point. And if you are in the right plane and if you are doing the right surgery, the bleeding will be less. That's my dictum. So I always talk about if you know the anatomy correct, and I think that sir has shown in a nice manner the both, and how the stitching also for the students, how to take a suture. That's also important. I think Dr. Shrikala will like to speak something.
No, I was wondering if Dr. Bailey sir had a small clip of his way of doing sacrospinous. That would be great if you can see it.
We will have one more session soon. Shrikala.
No, he said he has a short clipping.
Piley sir and Dr. Saraogi, these are the encyclopedia and the stalwarts. We should have
Stalwarts and
session
legendary
because
people.
our Archana is busy in another sessions also. She's just doing her campaigning. So I think we will conclude today, and we will have one more session very soon in our grand rounds or in a solstice program. Yeah.
Sarogi sir, really a wonderful presentation, sir. Loved all your punch Bollywood dialogues and punch Bollywood those cartoons.
And more of a debate sort. Like we are fighting with some laparoscopic surgeons. That was like that. Yes, sir.
So I think should we propose a vote of thanks?
Yes,
Kavita Di?
Seema Didi wants to speak any line because she has nothing. Anything? Seema Didi, unmute yourself. Unmute. Yeah.
It was a wonderful, wonderful session, and to listen to such stalwarts on this subject was such a privilege for us. And we have taken so many practical points out of it, and they will be adding to the pearls of our practice, I am sure. And everybody must have been benefited by them. Both the presentations were very nice, and also Archana spoke on sacrospinous fixation very nicely. So I'm really thankful to be in the part of this webinar, I should say, and thank you very much.
Thank you for being with us.
As a secretary, I propose the vote of thanks. What to say? I think we all will be thinking of what we heard today and trying to incorporate it in our daily practice. I am really thankful to Dr. Bhatt and Dr. Binu Kushwaha, post holders of SOFC MP, Dr. Archana Basair for curating this webinar so meticulously, our chief guest, Dr. Sukanta Mishra sir, our guest of honor, Dr. Shrikala Prasad, and Dr. Bhatt for her expert comments. We are extremely thankful to our speakers who brought the years of experience and expertise in such a short time, Dr. Saraogi sir, Dr. Piley sir, and Dr. Archana Basair ma'am. We also thank our chairpersons for their expert comments and analyzing the sessions so beautifully, Dr. Vrinda Joshi, Dr. Binu Kushwaha, Dr. Shweta Yadav, Dr. Seema Vijayvargiya, Dr. Anjali Kanhare, Dr. Sumitra Yadav, and Dr. Elizabeth Jacob. And last but not least, our wonderful master of ceremony who conducted the webinar so beautifully. And also thank to Mr. Sudeep from Pharmet for giving us the platform for this and conducting it. Thank you all, our teachers, seniors, and all those who logged in and learned from this webinar. I thank them all. Good night.
And I'm always proud of
I would like to thank Jyoti for really
We are proud of Jyoti Karan.
organizing it so well, beautifully connecting with everybody, and
Thank you,
just making sure that everything runs on
Archana, we
time.
will have part 2 soon.
Yes, we will.
We'll have part.
Thank
Yes.
you, everyone.
I think we have started now the MP Saucy. Our
Yes.
Kavita madam is now, in a gear
Geared
again.
up.
So
We need to
we
make
will be
it
doing
strong.
sessions. I think Beenu and Jyoti and you, like every once a month or maybe something like that, we can
We'll have
continue with the.
another part 2.
Yes.
Dhurandhar 2.
Okay. Thank you, Kavita Di. Thank you, everyone. Good Friday to all of you. Good weekend. And
Happy
you
come
so
over
much.
to Indore for National VP Conference, which is on 8th, 9th, and 10th May.
Thank you. Thank you, everyone.
Thank you, sir. Thank you, sir. Always. Thank you so
Bye.
much.
Thank you, ma'am. Thank you. Thanks, everyone.
you.
Good night. Thank you.
Bye-bye. Good night.
Thank you. Thank you.